Tumor arising from odontogenic epithelium, ameloblastoma, which is also called adamantinoma, adamantoblastoma, multilocular cyst. The ameloblastoma is true neoplasm of the enamel organ type tissue which does not undergo differentiation to the point of enamel formation. Robinson described it as tumor as usually unicentric, non-functional, intermittent in growth, anatomical benign, and clinical persistent. The term adamantomenoma was coined by Malasis in 1885. It is replaced with the term ameloblastoma as suggested by Churchill in 1934. It is the second most common neoplasm with odontoma. After odontoma, it is the second most common neoplasm. Most authorities consider the ameloblastoma to be of varied origin, although the stimulus initiating the process is unknown. Thus, the tumor may be derived from cell rests of the dental organ, either remnants of the dental lamina or remnants of Hartwig's shield. Second one is epithelium of odontogenic cysts, particularly the dentigenous cysts and odontomas. Third one is disturbance of the developing enamel organ. Fourth one is basal cell of the surface epithelium of the jaw. Fifth one is heterotrophic epithelium in the other parts of the body, especially pituitary gland. Clinical features: a wide age range of the occurrence of the tumor from 10 years through 90 years has been reported. Most cases between the ages of 20 to 60 years, with 30 to 39 years of average age at diagnosis. Only about 10% of the cases are reported arises in children. No significant sex prediction has been reported. Asian populations are the most affected. Commonly, the presenting complaint is slow growing, painless, bony, hard swelling resulting in facial asymmetry. Large lesion may present with mobile teeth, pain, and paresthesia. These lesions are locally invasive, can infiltrate the medullary space, causing erosion of the cortical bone. Ameloblastoma occur in all areas of the jaw, but mandible is the most commonly affected. More than 80% of the cases within the mandible, most commonly in molar angle ramus area. Maxillary tumor tends to occur slightly in older patients than do in mandibular region. Asians seems to have fewer tumors involving the ramus than do whites or blacks, whereas blacks have an increased frequency of tumors in the interior mandible compared with that of two groups. Classification of ameloblastoma: central or interosseous 99%, unicystic 30%, multicystic solid 86%, peripheral or extraosseous found in the gingiva and mucosa of the alveolar process, that is 1%. In the absence of the treatment, the ameloblastoma keeps on enlarging and it causing thinning of the surrounding bone, leads to fluctuation and eggshell crackling. Since it is not encapsulated tumor, it enlarges and invades into the neighboring tissue by replacing them rather than pushing them as seen as in the cyst. Invasion of the medullary space is the first feature. When the tumor attains large size with bone erosion, then there is escape into periosteum and mucosa and muscles of the adjoining region. Facial asymmetry will be seen. Root resorption is caused without osteoclastic activity. Locally aggressive invasion in the maxillofacial area may compress vital structures, obstruct airway, impair swallowing, erode major arteries, or invade middle cranial fossa. Its size may range from lesion as small as 1 centimeter in diameter up to the disfiguring tumor measuring as large as 16 centimeter. In maxilla, it may enlarge to involve the maxillary sinus, nasal cavity, leading to nasal obstruction, and even it can spread to the eye. Though it is benign, locally invasive lesion, in some rare instances or later stages, it should spread to the distant sites. The factors contributing to the spread include duration, extensive local spread, and other factors. Occasionally, transformation into malignant form, metastasizing to lung and long bones. Most common sites are lungs, and other regions include lymph node, liver, spleen, kidney, long bone, skull, cranium, ileum, etc. Radiographic feature: the ameloblastoma has to be described classically as a multilocular cyst-like lesion of the jaw, exhibiting a soap bubble appearance. In many cases, however, the lesion is a unilocular one, present no characteristic or other features. The periphery of the lesion is smooth and thinning of the cortical plate is seen in the jaw, expanding advanced lesion. Sometimes displacement of the impacted third molar can be seen. Ameloblastoma tend to occur more commonly anterior to the molar region in the both jaws. Desmoplastic ameloblastoma often show area of radiopacity and radiolucency with ill-defined borders, mimicking a fibrous osseous lesion. Cystic ameloblastoma is a term frequently used in refer to some of these neoplasms. Histological features: there are 6 histological subtypes of ameloblastoma, that is follicular, plexiform, acanthomatous, granular cell, a basal cell, and desmoplastic. The follicular type of ameloblastoma has the highest rate of recurrence. The follicular, which is simple ameloblastoma, is most commonly variant of it, consisting of many types of small discrete island of tumor composed of peripheral layer of cuboidal or columnar cell whose nuclei are generally well polarized. These cells strongly resemble ameloblasts and enclose a central mass of polyhedral, loosely arranged cell resembling the satellite reticulum. In plexiform ameloblastoma, the ameloblast-like tumor cells are arranged in irregular mass or more frequently as a network of interconnecting strands of cells. Each of these masses or strands is bounded by a layer of columnar cells, and between these layers may be found satellite reticulum-like cells. Next one is acanthomatous ameloblastoma. The cells occupying the position of the satellite reticulum undergo squamous metaplasia, sometimes with keratin formation in the central portion. Keratin pearls may even be observed in this acanthomatous ameloblastoma. In granular cell type, satellite reticulum-like cells get transformed into cells with coarse granular eosinophilic cytoplasm. This type is found to be more aggressive type with high chances of recurrence and metastasis. Next one is desmoplastic type. Small islands and cords of odontogenic epithelium in a densely collagenized stroma. Abundant nature of the lesion. By aggressive treatment, it is benign but locally invasive odontogenic tumor. It shows microscopic infiltration into cancellous bone. Tumor extends beyond radiographic margin. There is high recurrence rate. Its management is complete surgical removal with a margin of uninvolved bone. Standard margin is 1.5 centimeter to 1 centimeter beyond radiologic logical limit. Aim is to remove microscopic tumor extensions. First one is marginal resection, which is also called conservative resection. It removes tumor with margin without breaking jaw continuity. Its indication is small lesion, no soft tissue involvement. It is frequently used therapeutic measures. Least number of recurrences reported. Next one is segmental resection, means removal of segment of the maxilla and mandible up to including hemisection or more. It includes hemimaxillectomy and hemimandibulectomy. Most commonly used treatment. It has least chances of recurrence. It is noted that lesions most likely to recur after segmental resection are those over 5 cm. Reconstruction after resection, there is immediate or delayed reconstruction. Reconstruction plates are for temporary support. Non-vascularized bone graft can be used. Vascularized free flaps is gold standard. Fibular free chemotherapy may be sensitive to the platinum agents. It may have a role in involvement in non-surgical patient. Example: cyclophosphamide, cisplatin, vinblastine, etc. Electrocautery is electrocoagulation of the lesion including various amount of surrounding normal tissue. It's not been commonly used as primary mode of therapy. Much more effective therapy than curettage. There is 50% recurrence rate. Because of poor result, it is not being used as a sole method of the treatment. Ameloblastoma is generally radio-resistant. Postoperatively in patient with gross or microscopic residual disease. Patients who are poor candidate of surgery, radiotherapy is given. Thank you so much.